other bits and bobs.
Thank you, Ella. That's very good timing. We've just gone live on Facebook, so I'll just let everybody know again on Facebook. If you have any questions, welcome to this evening's webinar. If you've got any questions for the panel and Professor Alex Richter, please do drop them in below the video in Facebook, and a colleague will pick them up and get them over to us here. And final introduction, myself, probably many of you already know me, Nick. I work in patient advocacy as part of the patient advocacy team as healthcare liaison officer, and I am also a CLL patient, immunocompromised, so I have a bit of understanding with all of you in the audience. So without further ado, Alex, please take us away.
Thanks very much, Nick. Let me just check that we're sharing screens okay, if that's all right.
Yeah, that's great. Perfect.
That one okay. Right, so I've titled this Living with COVID and Blood Cancer. The government policy has been very much, we are now moving towards a living with this virus stage. And whilst that's fine for most of the population, and whilst for most people, you know, it is relatively mild symptoms, or at worst puts them in bed for a week or so. For many, the consequences may be more significant than that, and the policy of vaccination, especially if you don't respond so well to vaccination, doesn't really apply. So I just wanted to have a little think about where we're at, what we can do, and what, you know, what's new this autumn. So I just, with a little bit of doom and despondency, got a kind of an alert through from the BBC News saying COVID cases up again. And actually it's not a surprise, is it? We all, you know, people were relatively separated over the summer. We've got the schools going back, the weather's closing in now, much less time inside. So all the reasons why a respiratory pathogen might start to circulate again. So we've also had a slight increase in hospitalizations. So in 1 week, up from 3,400 to 4,000 individuals across the UK. And I would expect that to continue to rise over these autumn months. What else have we got? We've got the fourth, or for some, fifth vaccines being rolled out. And what does that mean? Is it worth having them? What the bivalent vaccine, a little bit about that I thought we could discuss. And I think it's also worth just acknowledging that the NHS is very, very busy. There's been a lot in the news. The NHS is struggling, the ambulance service is struggling. And so really supporting patients like yourselves who have immune deficiency associated potentially with your blood cancer. I think it's just giving some tips on how you can navigate this system, and what I would do in certain circumstances. So really, I'd like to think about some of the evidence for vaccines in immune deficiency patients, and it's not all doom and gloom. Actually, some, you know, the increased numbers of vaccines, we are seeing some reasonable responses. And I just wanted to share some of that with you. And I just wanted to think about positive steps that as individuals we can take forward. So making a plan, not just for COVID, but really thinking about all infections, because anyone that is vulnerable to COVID is also vulnerable to different types of infections. And then just a little think about what is known and unknown, and what research studies are currently open and recruiting. So the boosters this autumn, you should all be on the list, okay? Anyone with a blood cancer is eligible for a boost. And the other really important thing is that household contacts of people with a weakened immune system are also eligible. So the reason that we do that is because if you as someone with a leukemia cannot make a fully protective vaccine response, then we know that your most likely people that will transmit that virus to you are your family, okay? Because you live with them and it's close contact. And so if we can vaccinate the family members, that hopefully will just put a small ring of protection around you. None of these things are foolproof, but I think what we have to do is just do all the small things that we know can help to support you over this winter. And I think vaccinating the household members is part of that. Now, there are two different vaccines being offered this autumn. The original Pfizer or Moderna's, which you all would have had for your third or your fourth vaccines if you've had that already. But the other thing that you might be offered, and these are being prioritized for those that are most vulnerable, is the combination bivalent vaccine. So this is a mixture of the original Wuhan strain and the early Omicron virus, so Omicron 1-2. Now, a few things. There are 13 million doses apparently of the bivalent vaccine available, but there are 26 million eligible. So the government has already couched this by saying you'll get what you are given, but they are trying to prioritize the combination vaccine for those that are most vulnerable. The other thing, if we think about which vaccines to have, is, well, the original Wuhan vaccine hasn't really prevented infection, has it? And we know that with the huge rates and just waves after waves of Omicron infection through the UK population. But what they have done is prevented severe infection for many and most. Not for all who are immunocompromised, but for the majority of the population, that separation now between infection and severe disease does appear to be much better. So we've seen reduced hospitalization and death with all the Omicron variants to date. And actually that is true not just of healthy individuals, but of immune-compromised individuals, but just not to the same extent. So we know those Wuhan vaccines are working, and they've been working against all the Wuhan variants. So if you are offered a Pfizer or Moderna, I would be quite happy with that as your immunologist. So what about the bivalent vaccines? They're new, but they are using the same technology as the original Moderna vaccine. So this again is a Moderna vaccine. It's being tested in healthy individuals. It hasn't been tested for its immune response in immune deficiency patients. But we're assuming as the Wuhan portion of it is the same, we can extrapolate from the previous studies. So really, there's no difference to think why the technology means that there should be differences. So I'm reasonably reassured by that. But actually, there's a bit of a scramble going on at the moment because a lot of the studies have finished this autumn. All the COVID funding in research has been coming to an end. But the government and some of the funding bodies are realizing that we are going to need to be looking at the immune compromised patients going forward. So I can't tell you anything new today, apart from I've been on a number of meetings this week with various organizations to try and get some money to continue research funding into monitoring the immune response in immune suppressed patients over this winter. So I'm really hoping that studies are going to prove that this bivalent vaccine is at least as good as the Wuhan vaccine. Now, what I don't know is whether that little Omicron portion of the vaccine needs boosting and how that's going to behave. So there are some dynamics in this which are important to have some research studies for. Now, the other thing to say is, well, we don't know whether the Omicron 1-2 vaccine, part of the vaccine, will be as good or better against Omicron 4-5 and the sons and daughters of Omicron 4-5, which are starting to circulate now. So we're assuming that because it's originated from Omicron, that it will provide reasonable cross protection. But the caveat to that is I know a number of patients that have had Omicron 1, 2, and that didn't provide protection for them for Omicron 4, 5, and they've had both strains of that Omicron virus. So we're just going to have to see in a real world setting in immune suppressed patients whether there is any additional benefit to that bivalent vaccine. So it is exciting that we are starting to move towards different strains of vaccines, but I think it is so important that we have research to understand how this works. So do keep I will let Leukemia Care know if I hear of any studies, and I'm sure they'll be in touch with everyone in the group if stuff comes up that you can all contribute to, which would be fantastic. So vaccines, do they work in immune deficiency patients at all? Well, for most immune deficiency patients, they do something, but not for all. And there are two ways of looking at this. One way of looking at this is in the laboratory. And how do blood samples from patients with immune deficiency, what antibodies or T cells do they make? And the other way of looking at this is in real life. What happens when individuals are infected? So I just want to show you data from a study I've been doing called COVID, and this is a UK study looking in patients with antibody deficiency. So all of these patients have failed to make a response to the pneumonia vaccine. So by definition, they would have needed to fail on that to be eligible for antibody replacement therapy or immunoglobulin, you might know that as. And in this patient group that has failed to make vaccine responses and has low antibody levels like many leukemia patients, 76% have made some kind of antibody response after 3 doses of vaccine. So these vaccines really are much, much stronger than some of the other vaccines that you've been given, and are stimulating the immune system. So that's for me is good news. So there is a reasonable chance that many of you have done something in terms of an antibody response. But the other thing that we see is that some individuals have also produced T cell responses when they don't make antibody responses. Usually it's if you make an antibody response, you usually make a T cell response, but there are certainly cases where people who can't produce antibodies have made really quite good T cell responses. So the vaccines are working in some way, but I completely accept that they are not working as well as in healthy controls. But unfortunately, we're coming up for 2 3/4 years now of the pandemic. Despite huge national efforts and global efforts, we do not know a level of antibodies that causes protection. And I don't think we'll ever find that, because it's so different according to who you are, what strain of COVID that you're being infected with, what are your underlying health conditions. There's so many complications that actually we've never been able to say, right, if you get a level of this height, that's good enough for you. But what we've kind of done is we know that patients, we kind of in our head now have a range of results. So no response is really obvious. And then we can kind of look at what healthy controls do. And we could say, okay, well, that looks like a normal response. And then there's a kind of a low response. So people have antibodies present, but that's much lower than, but that is lower than a healthy control. And actually, that might be enough. And that might be some of the explanation why patients with immune deficiency haven't had such severe disease following vaccination than in that very awful first wave and the early Delta wave. But we know antibodies are important. And just in our study, we looked and compared complete no responders, so people that make no antibodies, with those that make some response. And we did find that hospitalization and death was much lower in patients that had responded, at least some response, okay? So even that some response is important. Now, what's that telling me? That's telling me that the people that aren't making any response, antibody response to vaccine, are in a more vulnerable group. And so therefore, it is more important that they have advice on seeking care immediately, getting the antivirals and potentially the monoclonal antibody therapies on board very rapidly. But we don't all know this information. And actually, it is really difficult to say to a patient with, you know, CLL or AML or CML, it's so dependent on where you are in your disease process without testing what your antibody status is. And it also depends on how long it was after you had your vaccine. So it is difficult, but in principle, we know that there will be some groups on some medications, which I'll talk about in a minute, that are more vulnerable. Now, the other thing that we found is that if you can't produce antibodies, you're also much less able to clear the virus. And so what we found is that people that had persistent viral infection, and if you look at the graph on the right-hand side, we've got people that have been positive at 200, 240 days. But then if you look down the graph in the non-responders, we've still got people positive at 90 days. So 3 months is quite a long time. And the way we've done that in the study is by sending regular swabs out to people after they've been positive. So not being able to produce those neutralizing antibodies may mean that you have an ongoing infection. And that's just worth knowing about in terms of, I know people having to attend for their chemotherapy. It's very frustrating if they're continuing to test positive, and also if they're meeting other friends that might be vulnerable. So it's just worth being aware. And then some of that can be helped if you have a monoclonal antibody like sotrovimab when you have your treatment, early treatment. But we're still trying to understand how long it takes and how much antibody you might need to clear the virus, because this certainly doesn't happen to everybody, and there is a real spread. And there are some, probably the most immune suppressed, that find it very difficult to clear the virus. Now, when I talked about which treatments and which patients, this is a study we did looking at a rituximab cohort. I think I'm speaking to a very educated group here, that most people will know that rituximab is a treatment that we use to get rid of B cells. And this is very useful if you have a kind of B cell cancer. So we also used rituximab, you'll see here, there's a rheumatology cohort, to reduce inflammatory conditions. But just thinking about the hematology cohort, a major determinant of vaccine responsiveness is the presence or the absence of B cells. So if you are on rituximab or one of the other B cell depleting agents, such as ibrutinib, your ability to make an antibody response is much less. That potentially doesn't mean that other parts of the immune system, it's not doing something, but your ability to make antibodies is less. So in my head, I would put in a higher risk group those on rituximab, ibrutinib, those that have been within the first 3 months post bone marrow transplant, and those who've just had CAR T-cell therapy. So these are the people who are least likely to have B cells. And what we know from looking longitudinally is you are really, if you've had rituximab, it is really, only about within 6 months, you've only got about a 30% chance of making some kind of antibody response, which is still much better than nothing. Some people will be doing something, and that's because B cells hide in tissues and rituximab doesn't get to them. And so some B cells can be made to produce antibodies. But just, I wanted to illustrate to you that not all leukemia patients are in this group of not having B cells, which I think puts them at highest risk of not making antibodies. So what we've also done is looked at real life data, and we've looked at what's happened over the waves in terms of hospitalization and death in patients with immune deficiency. And things like vaccination and early treatment have had an absolutely enormous impact on outcome. This little graph I just wanted to show you because it tells me something. So if you look at the red dots, that is the general population, okay? And from the Wuhan strain through the Alpha, the Delta, the Omicron, I think we're all familiar with these Greek terms now. You've got an accumulative percentage of the population being infected. So, almost 60% of the general population has now had COVID. It's unusual that people haven't had COVID. But if you look at the patients in our immune deficiency study, COVID, actually we're more like 18 to 20% have been infected. Why is that? That's because so many of you are still shielding. And you're still protecting yourselves in a much more effective way than the general population from infection. Some of it might be not strict shielding, but just simple measures that you as leukemia patients are doing, such as continuing to wear masks, being careful about social contacts, inside, avoiding busy places, public transport. All this is telling me that you are effectively reducing your risk of infection. It doesn't mean patients aren't getting infection. And I know a number of patients, you can see here, very many more have had Omicron than any of the other pre-infections. And that's similar with general population. But that shielding and you are just much better at infection prevention. So if we look in the COVID study, in the first cohort, in the first wave from March to June 2020, hospitalization was, well, if you combine hospitalization and mortality, it's gone from 20% down to 3%, 3.4%. So that's, I don't think COVID has got milder, because we still know that unvaccinated people end up in hospital. But this is the benefit of vaccines and the early treatments with antivirals and the monoclonals. So that's fantastic. But this is the point I keep hammering home to decision makers, is that although things are much better for immune deficiency patients, it's still, you haven't had the proportionate improvement that the healthy population has had. So for immune deficiency patients, the hospitalization rate is still 9.9% for immune deficiency patients, as opposed to 2.2% in the healthy population. And the fatality rate is 2.7% as opposed to 0.2%. Now, this is from a relatively small study, with 1,500 people in it, but it just gives some idea that although things are better, they're still not equitable, and it's still not as equal as the general population. So with one hand, I want to kind of reassure you and say, things are much, much better. But equally, I think, that there is still a vulnerability, and that vulnerability is your vulnerability not just to COVID, but to other infections as well. Now, the other worrying thing to me, which is relevant, is that there might be an education package around this, not just for patients, but for the CMDUs and clinicians, because in our study, and we know that study patients tend to be motivated, articulate, often expert patients in my book. Only 61.4% of this group had treatment from a CMDU. And what we did find from this group, that if you were treated with either antivirals or monoclonals, you were much, much less likely to go to hospital. And mortality was also slightly improved. So I think a key step for me is patients knowing they are eligible for CMDU treatment, which is the COVID Medicines Delivery Unit. And then the other aspect of it, because I suspect there's going to be a few people in the chat say they got COVID, they were eligible, and they were turned down, is really having the just being absolutely certain with the CMDU that your specialist has told you that you are eligible. And as a patient with COVID, you are eligible if it is within 5 days. It doesn't matter that you have mild symptoms, because the symptoms can develop, and then you will not be eligible because it's greater than 5 days. And there is this risk of persistent virus. So there's a really delicate balance, isn't there, with where we are this autumn. And infection management in blood cancer is not a new problem. This is what I've done every day for the last 15 years. But we've got a new infection. We know that the risk of any or more severe infection, any infection, is higher than the general population. Okay. So there's a real balance, isn't there, between avoiding all infection through restricted social contact, but also all the harm associated with this. And I fully hear and, hear that kind of all the, the social isolation, the economic consequences of it, the mental health consequences of it have just been enormous. So there is a real balance to be struck, isn't there, between avoiding all infection, which actually is impossible. We've got a respiratory virus, so it is impossible to never get sick. But we can manage that risk as best we can, or you can think about the management of that risk. And that's a very individual decision. And it will depend on how you're feeling in yourself, what your economic circumstances are, what your family situation is like. But actually, I want you to think of this not just as how you prevent COVID infection, but actually how you prevent all infections like pneumococcal pneumonias, like influenza. All of these are relevant. So just thinking very generically, I just encourage all my patients to be expert patients, because you know yourself better than I know you. And you certainly know yourself and how you're doing often better than your non-specialist care team. So I go through the cycle of the first step in treatment for infection is you recognizing that you've got an infection. And that's not always as easy as it seems, because often you are on treatments that suppress the immune system. So I've just come away from teaching medical students for an hour, and I teach them that infections present with high fever, feeling unwell, aches, not feeling hungry. But all of that might be untrue in patients who are on immune suppression, because that immune suppression blocks all the chemical signals that produces those symptoms. The reason we have those symptoms is because those chemicals help us to fight the infection. Your body temperature raises, its temperature goes up to try and kill the pathogen. It's part of it, it's trying to control the replication of the pathogen. But if these chemicals are blocked by immune suppressive drugs, you may not get a fever. So your ability to work out why you're poorly or what's going on may not be as straightforward, okay? So that's why I always say to patients, if you're not right and something's not right, don't wait until you are really unwell. You know, do seek medical attention. If you are coughing and you think you've got a chest infection, don't think it's necessarily just a cold. If you're on immune suppression, it is worth getting checked out, because so many patients I know with leukemia do end up in hospital with pneumonia just because they've left it too late to present to their GP. So along with early identification, then comes early treatment, because if you treat a chest infection before it really establishes itself in the lung, it is less likely to become pneumonia and need hospitalization. So early treatment, it's making contact, getting lots of it through the GP or through your specialist team. Some of you will have direct contact with, and some of you at home will have rescue courses of antibiotics prescribed to you. So however you access your treatments, just be aware that, you know, hanging on and being brave when you have immune deficiency is not necessarily the right thing to do. And seeking care early helps you to knock the infection in the head. It's much, much more difficult to get rid of an established infection. Now, you may be started on treatment, but we know that patients with immune deficiency often have more unusual infections, and so don't necessarily respond to first-line treatment, but also often need longer courses of treatment. And I'm sure many of you will have experienced this, that one course of antibiotics just didn't do the trick. So I encourage you all, if you are not responding, to please go back to whoever gave you that treatment care. Okay. So that's just looking in general at infections. Why do we overlay COVID onto this? Let's think with early identification of infection. So the amount of times people said to me, oh, I thought it was only a cold. We often are seeing COVID starting as cold-like symptoms at the moment. So if you do become unwell, please do a COVID test. You will be eligible through the NHS website. I'm sure someone from Leukemia Care can put the link up in the chat. And they will be able to make sure that you have a test and or even have tests at home in case. Now, at the moment, the tests that are being given are the lateral flows. Now, I don't know if you remember back to the early days of COVID, but there was a big controversy between, with the rollout of lateral flow testing, because the lateral flows are less sensitive than the hospital PCR swabs. So what I say to patients is, yes, swab, but just because you're negative doesn't mean you don't have COVID. If you are unwell the next day and you haven't recovered, I would do another test. Okay? Just because you are more likely to pick it up on 2 tests or 3 tests, and do make sure you do a proper throat swab and nasal swab. We're seeing lots of patients that are less likely to be positive if they just do the nose, and getting a really good throat swab is important. So early identification of infection, that's also important, because if you're going to be eligible for early treatment, we need to catch you early. We know that earlier you are given antivirals or monoclonals, the more likely they are to work. So if you have a positive test, it's important to register that test, partly because it triggers a pathway of care, and partly because it keeps records going, as we're doing so little monitoring at the moment. So you can either register the test online through the website, where you can order the test from, or call 119. Okay, that's your quick call number. Now, by doing that and saying that you are eligible for treatment because you are vulnerable, you should be on the list at this point, but many aren't. So it's just worth just double checking everything. Just saying that you are vulnerable and you have a blood cancer puts you in that vulnerable group. Someone from the CMDU, the COVID Medicines Decision Unit that give you the antivirals or the monoclonals, someone should contact you within 24 hours to make an appointment to bring you in. But belt and braces, we are sometimes finding that that's taking some time. And we just recommend that it is worth letting your specialist team know, and that might be that you're cared for by the GP alone or by your specialist centre. Just let people know that you have tested positive. That just allows us to kind of keep our records up to date. But also, if you haven't heard from the CMDU, we can chivvy that process along and make some phone calls for you. So if you haven't heard, your 3 options are calling 111, and they will contact the local CMDU, calling 119 again, calling your GP, or calling your specialist centre. But keep pushing until you get someone from the CMDU to contact you back. So when you speak to 119, just ask for a referral to the CMDU for antivirals or antibody treatment, because you are eligible for blood cancer. Now, this is regardless of whether your symptoms are mild or whether your symptoms may be slightly better today. It's important when the CMD rings you that you let them know that you do have a leukemia. We have heard the odd case where people with a leukemia have been turned down because they were thought to have mild disease. But the recommendation from the specialists, and I think from Leukemia Care, is you are eligible. So just push back and say, I've been told by my specialist that I am eligible for treatment. If you still don't win, then I think the best thing to do is to contact either your GP or your specialist for them to support and try and fight your case, which I've done on a couple of occasions. Hopefully it's happening less and less now, but just to empower you to be that expert patient, to push and say, no, I know I am eligible for this. Now, the proviso on this is that you need to be within 5 days of a positive test. So that's why I'm saying do push, and do push early, because there is this window of time for treatment for the guidelines. So if you get called in for treatment, it would either be for the monoclonal antibody sotrovimab, but not all units are using this. But most units are using the antiviral treatments. Now, these are both proving to be really effective in immune suppressed patients, as we've already seen. But just let's go to seek care if not responding. We've seen a few patients who, after their antivirals, their 5 days of antivirals, have felt unwell a few days later. And it's kind of, it's a bit of a rebound. So we've suppressed the viral load, but it's bounced back again. Okay, so we've seen that. And we've seen that not everybody has cleared the virus. So a very small number of very immune suppressed patients have not cleared the virus despite of this. So most patients are doing really, really well with these treatments. But I just want to put a little flag out that if you're not getting better, to please seek further care, especially in those of you that are really immune suppressed, because one, it can be persistent virus, but two, you can also be vulnerable to other infections. And we see a lot of what we call co-infection. So as well as having a COVID virus, you can get a secondary bacterial infection. And some patients will need antibiotics. So yes, if you're not responding, please go back and ask for some more help. So I mentioned about the persistent virus. Not all clinicians know about this. So if you're not better, we have seen people positive on swab, as I said, for quite a long time. And not feeling well, and we've had to come up with some creative solutions for treatments and retreatments, mostly in hospital. The other thing just to mention is people can be negative on swab, especially if that is lateral flow, and then the virus come back. We've had numbers of cases of that. So if you are persistently not feeling well, then do retest. Okay, don't accept one test as being negative if you think that you're continuing to be unwell after COVID. So, gosh, the pandemic is evolving, isn't it? And to be honest with you, we don't know what's going to happen next. What I do know for sure is there will be more variants. The myth that viruses get milder is not true. Think about flu. We've got good years and we've got bad years. But why would a virus get milder? It needs to get less mild because it needs to reproduce and continue to circulate. So my guess is that we will have some with worse immune escape, i.e. be able to evade vaccines, and some not. And actually knowing how these vaccines protect against these inevitable future variants is going to be really, really important. I'm focused quite a lot at the moment about thinking how we can improve vaccines for immune deficiency patients. And, over the last few years, we've got improved kind of boosted flu vaccines for the elderly and the immune suppressed. And we call that adjuvant. So it's like an extra little boost vaccine to try and stimulate the immune response. And we may need that for some patients. And then the other thing is that we might need mucosal vaccines. So ones that we have through the nose or through the mouth, because that's where the virus comes into the body. So there's going to be quite a bit of, hopefully, ongoing development in this area. Gosh, can we keep boosting forever? Or is there a point where, we can't boost what's there continuously? Do we need to boost in different ways? There's no evidence of that so far, but where we saw that you've got a much higher response with 2 and a much higher response with 3, we think that we've maxed out, or we're starting to max out now. So the response to 4 is similar to a response to 3. So the response to 3 dips down and then we can boost it back up again. And I think that's what hopefully we will do this autumn. Do we need to use these combination vaccines? And actually, if we're thinking about a bivalent, so 2 different type of strain vaccine, the flu vaccine that you'll have this year will have 4 strains in it. How are we going to get these different strains? And then the other thing I want to think, we really need to think about is how has COVID really identified those individuals that are most vulnerable to infection? And how can we support our patients with secondary immune deficiency due to their blood cancer and prevent them getting other infections? How can we improve early treatment and vaccination for different pneumonias and flu? So just, what is the legacy from COVID that we can take forward for improving infection control in blood cancer patients? There's been a lot of discussion around using antibodies to prevent infection. So you have it not to treat an infection, but you have it early. So we call it pre-exposure prophylaxis. Now, we do this in my antibody deficiency patients. We give them donated antibodies from people, but those only last 3 to 6 weeks, whereas they've engineered antibodies against the COVID virus, which can last 6 months to a year. And one of those that's been in the news is Evusheld. And it was originally part of the government strategy for preventing infection in those that can't make a response. Now, the government's made a controversial decision, as many of you know, not to purchase Evushelds this winter. Partly based on it being not as effective in the laboratory against the newer Wuhan strains. But I've already said, there's a big difference between what happens in the laboratory and what happens in real life. And actually, for many of us, knowing that we won't get severe disease is probably good enough. We're prepared to tolerate some degree of infection. So I think there's been a significant cost decision based around Evusheld. So there's been quite a lot of national clinical, all the patient groups have tried to ask the government to reconsider on this. And as clinicians, a number of us have tried to support this as well. And I guess my take on all of this is that, vaccines are producing antibodies against the Wuhan strain. And those antibodies that are produced in healthy individuals are protecting against severe disease to the Omicron strain. So why wouldn't donated antibodies from a monoclonal antibody? So in a form of kind of antibody equity. So it doesn't hold that we should be boosting against the Wuhan strain, but we can't be giving antibodies against the Wuhan strain. I mean, I appreciate that it's a difficult decision in terms of, who does this roll out to, who are the most vulnerable groups, who actually needs it and will benefit from it. But 32 other countries in the world have rolled this out to date, and I think that's increasing all the time. So I don't know what will happen in the future, but from what I can see, the decision has been made not to use Evusheld this winter. So really, what we have to do is make sure that those other pathways for care, including early recognition of infection, early treatment, are followed, because actually those things are really, really helping and working. Now, a different drug to Evusheld that we use in hospital at the moment is sotrovimab. And there is a very large study that is now open, and it's about to, all the opening phases of it, it's now going to start recruiting at a higher level, is PROTECT-V, and some of your hospitals may be doing this, so check with your specialists. And they are enrolling patients with either no, but also low antibody responses, because we suspect people with low antibody responses will also benefit from sotrovimab. Now, very interestingly, this study was supposed to start a year ago, but was delayed because of effectiveness against the Omicron strain. And the debate with, similar to Evusheld, that it has less response in the laboratory. But actually, what they've found is that you can overcome some of that by giving a higher dose of the sotrovimab. So originally we were giving 500 milligrams in the trial, but actually this is now going to be 2 grams if you are enrolled into this. So look out for Protect V. It is being used as pre-exposure prophylaxis, similar to Evusheld. Not everybody gets it because it's a proper what we call randomized control study. So some people will get it and some people won't get it. So we can make that comparison to really give that evidence to the government as to whether pre-exposure prophylaxis works or doesn't. And this is important to do because I'm thinking to the future. I know lots of people are worried about this winter, but I'm worried about protecting you from infections next winter and the winter after and the winter after and the winter after. And I think if we can make the case for pre-exposure prophylaxis, this is hugely relevant, not just for COVID, but potentially for flu, potentially from, some pneumonia treatments. So there might be very many diseases that we can protect patients who can't produce their own antibodies over winter and, enable that precedent. So sorry, Nick, I've babbled on probably far too long. So I'll stop there. Thank you so much for listening, and I'm really happy to take any questions.
Thank you, Alex. You've covered an enormous amount of ground, and I've got to try and apologise for everybody because we've got a lot of questions that have come in, and obviously we're really short on time because we've got a shorter session, just the 1 hour. So we will collect all of these questions and we will field them to haematologists and to immunology, to Alex as well after, just to see if we can get some responses so we can answer your questions. I think there's a few that we can group together quickly. We've literally only got minutes before having to run out, and apologies to colleagues and everybody for slightly overrunning, but I think it's only polite that we do. I was just going to ask you on the, maybe I was going to field a question to you, Ella, with regards to access to Evusheld. Obviously, we've had a few questions about views on Evusheld and about access, and obviously, Alex, you've just pointed out something, the pre-exposure trial with Protect V, great. There's a chance, 50-50 chance that you could end up with some, but you also pointed out in the data that we do very well as an immune compromised community because we shield. So potentially, in my own view, and it's probably the wrong one, is that trial could be flawed because without knowing whether you've got protection or not, you're going to carry on shielding. So that the incidence of infection probably won't change, but you'll be able to measure obviously the impact of that. So I just wanted to get a feel for what is actually happening with the charities, Ella, and what's happening with the process for Evusheld access at the moment. Obviously, it's a long process potentially, or a shortened process, but maybe you could just share what the charities are doing with the clinical community.
So just building on what Alex said, the Evusheld, or I should say preventative treatments, because there are a number of preventative treatments, as Alex alluded to, that are going through the NICE process, including Evusheld. They've been put to NICE, which is the National Institute of Care Excellence, and they will be going through the normal process that lots of cancer drugs go through when they get looked to be approved on the NHS or not. And as part of that, charities have the ability to be able to provide a patient voice submission to the appraisal. And Leukemia Care do this for other leukemia drugs. We do this every time that there's a new drug for leukemia that goes through the process. And we will also be doing this for preventative treatments, for example, Evusheld. So I'm currently in the process of compiling lots of data on the patient voice and on your views of Evusheld. We've actually recently launched a survey as well to gather more data on this. So I will post a link to that survey in the chat if anyone would like to support us with our submission. We'd be immensely grateful for your support, and it really helps us to amplify patient voices and patient views. So we will continue to do that and report on our progress.
Thank you, Ella. So if it's possible to post the link to that survey, or we'll forward it in the replies. Really important that we do get everybody's feedback that can do in terms of the value and the importance of access. And I think you pointed out that we're working in collaboration with many of the other charities. This isn't just one charity alone, and in collaboration with all of the clinical community. The pressure is we're not taking the foot off of that pressure at the moment. It's obviously a bit difficult with administration changes at the moment. Alex, I see you're busy answering questions there in chat. Thanks. Did you pick up on the question about the different types of monoclonal antibody therapies, Acala, and obinutuzumab and rituximab? There's a question there about how long before people are likely to get a response if they're in treatment with one at the moment, or if they're finishing treatment. Is that something you could quickly answer?
It depends on how many doses they've had and what other therapies that they've had. So bit difficult, but in the first 6 months, it is highly unlikely that it's less likely they're going to make a response. But it's when they get their B cells back that things will get a bit better. So that's usually between 6 months and a year, B cells start to come back.
Should you wait, or should you go with the philosophy?
At the moment, I would just vaccinate, because at the moment we are boosting.
Yeah.
So even if you don't get an antibody response, you may get some T cell response. So, I would just crack on with vaccination. So
we have to live by a mantra: some response is better than none.
At the moment, in the absence of any alternative treatments, this is the only preventative option we have this winter is vaccination. So, if you're still on treatment, and I would put it back maybe at a month most. I think this autumn cases are starting to tick up already. If you are out and about, it's probably worth getting your vaccine in.
Okay, thanks for that. Whilst we're on the topic of protective measures, there has been a question about somebody asking how immune compromised they might be, CLL in remission. We know certain conditions people are still immune compromised, and the question was relating to the face mask. How protective is the face mask to the wearer, especially immune compromised? As we know, nobody else is wearing face masks. And what are your thoughts about that, especially in
I think it's difficult to give you a percentage at the moment, but because it depends on how busy the environment is, depends whether you're inside, outside. But a surgical face mask isn't as good as an FFP2 mask.
Okay. And is it worth paying for an FFP3?
Well, it's all a balance of risk, isn't it?
Yeah. Okay.
So, if you're having to be on a busy commuter train,
wear a good quality mask.
I would be tempted to be in a stronger mask, or not go on the public transport. But, some people have to go to work. And so the best thing that you can do in that situation is provide yourself with the most protection. But even a surgical mask is probably better than no mask. So, I still wear a mask if I'm out and about. I'm sure, there's lots of studies to show that mask wearing does help to some degree. It's not perfect, but it stops at least something.
Thank you very much. Just a quick question. If somebody, for example, had their last jab in August, they're obviously going to be bypassing autumn, but they'll be due in November. Well, if they can still access the booster, should they?
If they still can, I would, because we know the vaccines are, probably lasting 4 months in healthy people. So it might be slightly less and immune compromised. So if you are eligible for a booster, I would, 4 months after in the autumn, November, go for it. That might work quite well from a timing point of view with the winter wave.
A lot of hematology specific questions that might not be your forte, but we've got a lot of questions around CML patients, post-transplant, post-use of immunocompromising drugs, still experiencing chemo effects, also other transplant patients, and being told that they're not eligible. I'm going to ask this to both of you because it's an important question. If people aren't on this, or they're being told they're not compromised, who should they get this qualification from? Should they be
First
talking?
of all, I would put back, because if they've got leukemia, they are eligible.
Okay. Irregardless.
Yeah.
Okay.
So it's not a it's in the guidelines that if you have leukemia, you are eligible.
And that's eligible for the post-infection treatments. What about the boosters themselves?
And they should be eligible for the boosters as well.
Okay, so Ella, fielding over to yourself, if people aren't on these lists and they're not being included or being turned away or being told they're not eligible, what sort of process would we advise people to take?
I think speak to your clinician, speak to your care team, speak to whether it's your GP that's your first point of contact or your specialist care team. They're the ones that are able to do it on a case-by-case basis. So they will be the ones who can tell you, whether you're immunocompromised, which all most blood cancer patients will be, or and hopefully support you as well if you're having difficulties accessing antivirals and also vaccines. And
of course, if people are having difficulties, still contact the charity.
Absolutely. We have our advocacy officer. I can put the email address in the chat, and also if any of your questions today are unanswered and you think that we might be able to help with them, please do feel free to drop us an email at advocacy. I'll put it in the chat now. Yeah,
I'm trying to be disciplined. I mean, there's another one from a CLL patient in a similar form, which is answered in remission. Am I still eligible? Absolutely, yes. You're a leukemia patient and you're post-treatment as a CLL patient, so you're more likely to be immunocompromised than some. So that's a definite yes. I'm just quickly looking through everything at the moment. I think for the moment, it's going to be very hard to answer some of the specific questions. There's one more that I'd like to address because I also had it on my notes before from somebody else. Question regarding having combined COVID boosters and the influenza jab. Should there be a time difference between them? Is it okay to have them both? Somebody's posted.
Fine to have them both. Fine to have them both. And actually, logistically, sometimes it's just easier to get them both done at the same time.
Is there an increased incidence of any adverse events on that? Somebody's posted they know a friend that has done, but is there a likelihood of increased incidence or reduced efficacy?
There's no, if anything, it's the opposite, because actually, you've got an inflammatory response. So that kind of potentially is more immunogenic. So we've often seen vaccines given together like that. Just some people, if they've had an adverse reaction in the past, may want to separate them. But that's a personal decision, not a medical decision. For practical purposes, I'll just crack on and get them both done at the same time. So, that they're in. But if you want to separate them, some people will react to both of them, won't they? Yeah. And if they'd rather separate them, that's fine. But there's
similar advice with regards to the flu jab. The flu jab is as important as the COVID jabs, immune compromised. What about those living under the same roof in terms of?
Then they will be eligible for vaccination as well. Yeah.
I'd like to thank you both. I'm sorry that we. I've got a shorter format, but as Alice said, we will respond to everybody. If everybody's got 5 minutes, I've got a few slides to run out. Ella, is there anything that I haven't picked up that you feel that we could quickly address whilst we have Alex before we shut shop?
Not at the moment, but I will just put the advocacy and also our nurse on our helpline, the number for that in the chat as well, because we have a clinical nurse who can answer some questions if they're more specific to do with medical queries. So I'll put that in the chat as well. I'm just doing that now.
Okay, I will just find us our slides if I can. As usual, let's try again. Let's see what it does for me. Aha, I have them here. So if everybody, thank you everybody for joining us and attending us in the evening. And Alex, thank you after such a tough day of lecturing. Just to let everyone know, Alex has been lecturing to her students for 4 hours non-stop, back to back, before she's joined us. So thank you ever so much for joining us. I'm just going to share some slides if it'll let me do it. Come on. There we go. I'm pressing the wrong button. There we go. Okay, I think I've got them in front of me here, probably in the wrong order. So just to let you know, services available from Leukemia Care. As we pointed out earlier, if you're having difficulties with regards to accessing boosters or accessing quickly accessing treatments once you test positive and you're having any barriers, please do get in touch with us. Information sources that are available from Leukemia Care. Obviously, we've got several other webinars coming up. I haven't actually published all of these because it's such a broad audience. I couldn't make them specific enough for everybody. What might be of great use to everybody, though, are our newsletters and our magazines. So, you can subscribe to these on the website, and these will be in your inbox or at your door. Podcast is another area where we help updating information, a great way of sharing patient experience. Always engage with social media. Look out for us on Twitter, Instagram, and Facebook. And the website is a font of information. And I've got a couple of slides here. Whizzing through very quickly, we have quite a portfolio of patient information books across all cancers and blood cancers, especially the leukemias, MDS and NPN. So please, if you would like information, regardless of what stage you are in your journey, just have a look on the website there. They're free of charge. You might find those helpful to bring it up to speed. The website, we have the COVID hub there where you can actually access what we've been talking about today, the latest advice on the COVID-19 vaccine and the pathway and processes, access and everything about the booster, as well as treatments for COVID. That's available on the Leukemia Care COVID Information Hub, and that's on the website. We've just published the Autumn Leukemia Matters, which is our quarterly magazine. Well worth a read, plenty of latest clinical updates and lots of information for fellow patients. So if you don't subscribe, it really is a good read. Support services that we offer. The helpline is also supported with a direct WhatsApp line, which you can access via the website. That's staffed during the week by a clinical nurse specialist and the support team, our advocacy officer. So, don't be afraid to reach out, especially in these times at the moment. There's somebody there for you. We run a national network, if you don't already know, of support groups, both national by disease type or locally, across different groups. You can access on the website there to get an idea of what's available in your area, and you can register through the website. And if you actually subscribe to communications from the charity, they'll keep you updated in all of that area. Welfare advice is something very current at the moment. Our welfare officer is very busy, which we can understand, all of us at the moment with the current circumstances. But if you are in trouble and you want to talk to somebody, get in touch. Advocacy support. Colleagues in the advocacy department who are welfare as well. We have our advocacy officer, Sophie, and co. They will help advocate for you if you're having access issues, or what we've just been talking about earlier, if you're experiencing issues with regards to accessing your booster or treatment. Online forums, these are available in the Facebook group, Health Unlocked. We also have a very good buddy scheme, which I'll just touch on. And we also have a counselling fund, which offers 6 sessions to people if you're looking for a bit of emotional and psychological support, where you can be supported to gain access to a counsellor. If you're looking to connect with somebody living with the same disease or experience as you are, if you're newly diagnosed or if you want to be able to talk to somebody quickly, we've just started a short scheme as well as our regular long scheme of providing you with an experienced buddy. Something well worth doing. I think for most of us living with a condition, meeting somebody else and being able to talk to somebody else with the same experiences, especially in this difficult winter, this would be something I would recommend to everybody. You can find the information on the website or call. Touch on our advocacy caseworker, do get in touch. Again, the same with the welfare officer. And I touched also there on the Anne Ashley counselling fund. So these are really important resources, especially when times are this hard and coming into this winter. They're there for you. Just finishing off, it's just an appeal to everybody. Financial times are hard. So if you're interested in fundraising of any small or large way, there are plenty of ways to get involved, even if it's just with a collection tin and placing that somewhere. Please get in touch with us so we can continue providing our support resources. If you're the adventurous type, and you're a runner, I'm not. Walking's my game, but things like this Run 50 challenge over an entire month, You know, if you're immune compromised, it's something you can do without crowds of people, as can a lot of the other initiatives. So, you know, would welcome anybody, bring people together in groups to do these activities. It's a great way of meeting people at a distance outside as well. If you're immune compromised, keep you healthy, keep you mentally sane. This one's quite extreme. We never know what's going to happen next year, but if you're a cyclist, we've got London, Paris, something for the brave and something for the brave immune compromised as well, I think. And just finishing off, as I touched earlier on, we've got our very active social media channels. So please do drop in if you users there and you know, that will keep you posted on everything that's going on through those channels. Sorry about this, what's the stop talk, and I'll leave you now with our phone number. So that's in front of you there, so that you've got the helpline number in front of you. Just don't be afraid to pick up the phone. We've got people there to help you who understand. And alternatively, just email support@leukemiacare.org.uk. So on that note, I'd like to say thank you everybody for joining us this evening. And Alex, can't say thank you is big enough. Fantastic talk, covered a lot of ground. And considering you've just done two-hour back-to-back lecture sessions and you've given your evening, we're incredibly grateful. Ella, thank you for being there for us this evening, and thank you for being there for everybody in the future. And everybody, thanks for joining us. Have a lovely evening and stay strong. And I guess we have to be careful out there and remain aware. We've been given messages, mixed messages, but we just have to remain vigilant. Good evening, everybody. And on that note, I'm going to see if I can end this session by stopping the share, and it should give me a best to end. So there we go. Good night, everybody.